Hi, my name is Nicole Harter. I'm a pediatric dermatologist with Children's Nebraska and an associate professor of dermatology for University of Nebraska Medical Center. Today, I'll be talking with you about pediatric dermatology, mostly discussing common kid skin rashes and when to worry and when not to. Our course objectives today are going to be to identify some common pediatric dermatologic conditions, gain some knowledge about when to worry about a rash and when to wait on an evaluation or referral, or when something is just going to possibly spontaneously resolve on its own. And then I'm really hoping to instill some increased confidence in making recommendations to families and caregivers regarding needs for further evaluation, whether with primary care, pediatrician, or a specialist, and if something needs treatment. Some goals today are: when is it benign or not worrisome? What is contagious? And what is actually worrisome versus what is just simply frustrating, which is a good chunk of our common pediatric dermatologic conditions. We're going to categorize these skin diseases into four main subtypes: a primary cutaneous infection, meaning like a skin-directed infection; a cutaneous manifestation of an underlying systemic infection or illness; a cutaneous hypersensitivity reaction, so kind of the skin's reaction to something going on inside, but not necessarily an infection; and then inflammatory skin diseases, which can commonly be misdiagnosed as infectious skin diseases. So our primary cutaneous infections we'll talk about today, and there are many, but these are the common ones that we'll go through, are impetigo or bullous impetigo, tinea corporatis and tinea capitis or ringworm, verruca vulgaris, which are warts, molluscum contagiosum, and then pediculosis capitis or head lice. So impetigo and bullous impetigo, these are highly contagious primary cutaneous superficial skin infections. They're usually caused by Staph aureus bacteria on the skin more frequently than group A strep bacteria. And then a form of impetigo will go through bullous impetigo, in which you get crusted lesions that also have blistering or bulla formation, is usually due to a Staph aureus bacteria. These infections are much more common in children than adults, infecting up to about 10 to 12% of children at some point in their life course. And what can predispose to an infection is just some minor trauma. So it could be scraping a knee, falling off of a scooter, or playing on the playground, or an underlying bug bite, or if they do have an underlying skin disease like atopic dermatitis or eczema, that can predispose as a way for bacteria to gain entry into the skin surface. They begin with these very red, weepy vesicles, so little fluid-filled balls, and pustules, so pus-filled vesicles. And then they transition very quickly to erosion, so open wounds with this classic honey-colored crusting. It's not always truly honey-colored, but that's the classic presentation. We'll go through a bunch of photos. And it's very common on the face, but as well as the extremities. And these kids are otherwise well. They don't have systemic symptoms. It's really not painful. It might be a little bit itchy for them. Here you can appreciate this well-demarcated, honey-colored, crusted erosion on the left lower cutaneous lip. And here around the nares is a very frequent location, especially in young kids. They get these superficial open erosions with a honey-colored crust. You can see the crusting here and a few discrete erosions here. And then a constellation of different photos here that we'll go through. So in this patient with skin of color, you may not, and this is a theme throughout our talk today, in different skin color types, rashes look different colors. So something red, a rash that's red on very fair skin will look more violaceous or hyperpigmented on darker skin. So here you can appreciate there's a little bit of an erosion with some scant crusting on the pretragal surface. On the outer knee, this patient may have had an underlying dermatitis that then got maybe scraped or eroded, and then gets thick crusting over the top, which is consistent with impetigo. And then this is that classic honey-colored crust in the left oral commissure. This patient has some deeper lesions of impetigo. These may have been bullous impetigo previously, and they're forming a black eschar or scab over the top. And you can see here it looks more violaceous or hyperpigmented in skin of color. And then on the forehead, glabella, nasal root, kind of those pink scaly papules, maybe a few that are resolving pustules, and the honey-colored crusting. So these areas start with very flaccid bulla, meaning a blister that's easily opened up and kind of peeled off. So usually you don't actually see a blister in bullous impetigo. You see what's left of it, the remnant. So you don't necessarily see this part that you see here, the blister roof and kind of some open denuded skin. And then you can get that crusting on top of it subsequently. And these do require oral antibiotic therapy. The bullous forms, it's a little bit deeper and a little bit more aggressive per se, requires an oral antibiotic. Here's another example where this patient just has these perfect little circles all over that did have a really, really thin blister roof, but those all got easily scraped away. And on the posterior neck of this child, you can see this nice kind of collarette of scale is one of the classic terms. And there's some crusting forming centrally, but you don't actually appreciate the blisters because they get wiped away so easily. And as I mentioned, in darker skin types, the redness, the erythema surrounding a lesion can be more purple and gray. It's really important to pick up on that when we're evaluating rashes of any sort in different skin types. For impetigo and bullous impetigo, the evaluation and testing we usually do is a bacterial skin culture, not always, but often, so that we can assess the type of staph bacteria, ensuring it's not MRSA or say a clindamycin-resistant form of Staph aureus, or if it is group A strep. Treatment is often with a topical antibiotic cream or ointment, usually prescription, but over-the-counter can be quite effective as well. If it's very widespread, if there's a poor response to topical antibiotic therapy or the blistering bullous variant, it does require oral antibiotic therapy. And the return to school is going to be after 24 to 48 hours of antimicrobial therapy, or if all areas have kind of healed or crusted over. You can try to cover areas with a bandage or clothing to prevent spread by contact. And then, of course, good hand hygiene, washing linens, clothes, and affected fomites, so whether it's towels, sporting equipment that have come in contact with the infected areas will be important in preventing reinfection, because reinfection is quite common. Okay, next is molluscum contagiosum. Molluscum is a very, very frequent thing we see here in dermatology. It's a very common cutaneous viral infection, and it's due to the pox virus. It's spread via skin-to-skin contact and fomites, so clothing, towels, sports equipment. It's kind of prolonged, moist skin-to-skin contact, very frequently found in environment of swimming pools, close sports, wrestlers, gymnasts, and then can be contained on sponges and towels as well, especially in the home. It's characterized by these very pearly, kind of shiny, they're not scaly, pearly domed, skin colored to pink papules. There can be a few or there can be many. They can have this little central dell or depression, and they like the fold areas we call intertriginous sites. So axilla, popliteal fossa behind the knee, and the groin. They can really be anywhere. When they become inflamed or irritated, they get very red, very swollen, almost purulent appearing. There's actually a little white viral ball or viral particle centrally within this dell. And when the body's immune system is waking up and fighting off this infection, it will mount a host inflammatory response that creates significant erythema and edema. And that's actually usually a sign they are going away and not that they're getting infected. They very rarely get infected. We have a term that's been reported in our pediatric dermatology literature called the boat sign, B-O-T-E, beginning of the end. So when all the molluscum get red and angry and swollen and almost look infected, it's the beginning of the end of the molluscum. The body will wake up, fight them off, they go away. And once you've fought off a molluscum infection, you do not get reinfected over time. Here's the abdomen of a young child. You can see a little bit of this boat sign. So beginning of the end, some erythema, some scale, and then some just very classic skin colored to pink, pearly domed papules. These are asymptomatic. You can see a cluster on the buttock and a phenomenon that we call Kebnerization, where if you get a wound or a scratch in a line, the skin lesions will also form in that line. Very nice boat sign here. Many of these look erythematous, edematous, and almost purulent, but this little dot here and here, here and here and here, that's actually the viral particle. And then a few pink domed pearly papules here, and you can see the central viral particles. Great example of boat sign here. You see classic molluscum on the chest, at the upper inner arm, and then these getting inflamed are on their way out. A single molluscum can be confusing for, what is this? Is it a tumor, a growth, a different type of skin infection? But that pink domed pearly nature. And then here you can see in the skin of color, it looks a little more tan brown, but you still see that shininess. And in the popliteal fossa, this is really common in kids that also have eczema, which frequently affects that behind the knee space. They can develop molluscum within those lesions as well. So one can develop a molluscum dermatitis, which is a form of what we call autoexematization. So your body's host immune system is kind of mounting a little bit of immune response, creating a scaly, itchy rash around the molluscum. And that's most appreciated in this bottom photo where there's scattered molluscum bumps here, but these pink scaly plaques are more of like an eczema reaction to the molluscum. And then when you get the autoexamination reaction, it's itchy, so they can scratch, and scratching is one of the mechanisms of spread. And so that is something we usually want to treat. All molluscum do spontaneously clear in the normal non-immunocompromised host, but it can take many months or years. Treatment is often chosen by patients and families, sometimes for cosmetic significance because it's visible and people are asking what it is, why is it there, can we catch it? Sometimes there's itchy or there's a concern for spread to siblings, classmates, otherwise. There's many treatment options, none of which is perfect for every single patient. But the primary one that I use in my office is something called cantharidin, which is a topical vesicant. It's a blister beetle extract. It's very well tolerated. We paint it on in the office. It dries for 24 hours. They wash it off the next day, and it creates a small domed vesicle on each molluscum bump. The healing process can be a little irritating because we've essentially created a bit of a scab on each molluscum bump, but it's probably the least painful and most effective thing we can do. And restrictions for patients with molluscum, truly nothing. There's no reason a child should be restricted from school or an activity because of molluscum. I tell families, they got it from someone, they may give it to someone. Of course, I'd like to prevent that, but this is too common and too rampant to restrict children from activities. You can try to cover it with clothing when possible. And otherwise, if they're in a close contact sport, something like swim lessons and they have a kickboard or goggles, I just make sure they're using their own kickboard and goggles and not borrowing one from a friend or a family member. Verruca vulgaris, warts, another common viral skin infection, but this one is due to human papillomavirus or HPV. Warts are harmless, but they can be very painful and very stigmatizing because they're often in highly visible locations. We have frequent auto-inoculation, meaning you have warts in one place of your body, say your hands, and you're a nail biter, and you bite your nails and you transfer them to your face, so auto-inoculation. And then Kebnerization, again, the phenomenon by if you get a wound or a scratch, you can get warts all within that new area of wound or scratch or trauma to the body. Prevalence is very high, up to 10 to 20% of school-age children will develop warts at some point. And HPV warts are transmitted via, similar to molluscum, skin-to-skin contact from warm, moist fomoids like locker room floors, pool deck, shower. I see this, again, a higher incidence in our patient population that has like a close contact physical sports such as wrestling, gymnastics, and swimming. The incubation period can be very long, several months prior to a lesion actually developing, and the duration highly varies. About 2/3 resolve over a 2-year period, but sometimes they last for much longer than that. And they can occur anywhere in the body. Any epidermal or mucosal surface of the body can develop a wart. Here on the nose, you're seeing this kind of exophytic, scaly pink papule with that kind of like white gray scale over the top. On the bottom here, this is a filiform wart. Filiform warts have more discrete projections. They almost look like skin tags more, but they're going to have that kind of white, scaly, crusty superficial component and like little tiny castle-like projections sticking out. This is a ring wart on the upper lip. So what happened here is this was probably treated with liquid nitrogen or a cryotherapy, and it got the center portion of the wart, but it wasn't fully treated. So it spread the viral particles out with the spray of liquid nitrogen and created the ring of virus at the periphery. We try and avoid doing this in our office. And then here is a periungual wart, so a wart that's right at the lateral nail fold, kind of getting underneath a nail. You can see those little tiny thrombosed capillaries. Those are the vessels feeding the wart. That's very classic for picking up a wart on exam. And it's causing a little bit of subungual hemorrhage or bleeding here, just a trauma of the underlying nail bed. And this is another, you can see this very nicely, beautifully scalloped border for this wart on the plantar surface of the heel. And it's getting a little bit of bleeding into it, probably from trauma of walking on it. And then you see all these pinpoint thrombosed capillaries, which are classic for wart too. More warts you're seeing on the nasal tip of this child here with skin of color. It looks a little more hyperpigmented brown-gray. On the palm of a fair-skinned child, more pink with that kind of silvery yellow scale over the top. A small palmar wart here, little tiny skin-colored warts in the perioral distribution, and then multiple kind of pink warts with that silvery gray superficial scale on the dorsal hand. We have verruca plana, which are flat warts. Flat warts are just a different subtype of wart that tend to be much less colorful and less textured, very, very thin, often mistaken for acne because they do like to be on the face. Here you can see these kind of skin colored to pink thin papules and this Kebnerization phenomenon. So they might have accidentally scratched their forehead and then the warts all lined up in a line there. Another example of Kebnerization here in this line. And then warts, so treatment, as I mentioned, 2/3 resolve over several years, about 24 months, but recurrences are very common. You don't form lasting immunity to HPV after clearing a wart infection, which is in contrast to molluscum virus. Once you clear that infection, you will not get them again, except for some extremely uncommon circumstances like profound immunosuppression. But for warts, you can have recurrences. Treatment is not necessary for warts by any means. Oftentimes it's painful, requires multiple repeated treatments in the office. It can be very time consuming, very expensive. Things to start with: over-the-counter wart remover, salicylic acid. Trade names would include Compound W or Dr. Scholl's. It's a 17% salicylic acid solution that's usually painted on, and then it's much more effective if it's occluded with a Band-Aid or truly duct tape. Duct tape is the most effective. Cryotherapy, this is liquid nitrogen freezing treatment in the office. They make over-the-counter cryotherapy kits. They really don't get cold enough to do much of anything. I do not recommend them. And then other things we have by prescription are going to be a topical retinoid, topical 5-fluorouracil, which is a topical chemotherapeutic agent that does help with rapidly dividing cells, and that's why it helps with warts. Topical imiquimod, topical cidofovir, other antivirals. Intralesional immunotherapy, which I do a lot of in my practice, where I inject a small amount of Candida antigen because most of our bodies mount an immune response to Candida, and inject a small amount into one wart, not all of them, just one, and it helps stimulate the body's immune response to help get rid of the warts. Again, usually done at repeated intervals every 3 to 4 weeks for prolonged periods until resolution. Other immune modifying therapy would be oral cimetidine, which is a type of antihistamine that we do think can gently stimulate the body's immune system. And then rarely different forms of laser therapy if we have really maxed out all of our treatment options and we're trying to be as aggressive as possible. Big thing to know is they're common. They don't have to be treated, but if they want to be treated, we do have many, many tools and tricks to find the best treatment for a patient. Okay, tinea corporis, tinea, which is ringworm of the body, okay? There's no worms involved with ringworm, but it's classically called ringworm. It's a superficial fungal infection of the skin due to a dermatophyte. Dermatophyte is the type of fungus that specifically causes tinea. It's transmitted through direct contact with people or animals or fomites. And risk factors are excessive heat, high humidity, and tight-fitting clothing. So we usually see more of this in the summer months. And it includes different parts of the body. Tinea faciei is of the face. Tinea pedis is of the feet, athlete's foot. Tinea manum involves the hands, and tinea cruris is of the groin, also called jock itch. The differential diagnosis for a tinea or ringworm is often a nummular dermatitis, meaning an eczema that's kind of in a round scaly plaque, psoriasis, viral eruptions, including pityriasis rosea, and then other less common things, including granuloma annulare, which is like a ring-shaped rash that children get beneath the skin that's not scaly and not itchy. And then an allergic contact dermatitis, where something came into contact with the skin and is causing a rash, or an irritant contact dermatitis, where something came into contact with the skin and just irritated it enough to create a little bit of dermatitis and rashiness. A lot of things look like tinea, and tinea looks like a lot of things. So just trying to get some key pearls of the physical exam for you to help address. These are annular, meaning ring-shaped, red or violaceous, itchy, scaly plaques. They often have a very active kind of palpable scaly border and some central clearing, and we're going to go through some photos. It's going to be red or pink in lighter skin types and kind of a deep red or violaceous in intermediate skin color, and violaceous to kind of gray-brown in darker skin color. Sometimes patients will actually have pustules or little follicular papules within their ringworm. That term is called Mayoki's granuloma, and that means that the ringworm has gone, the dermatophyte has gone down the hair follicle, their hair shaft of the hairs, and that will not get better with topical treatments alone. It means it needs an oral antifungal therapy. So some examples of what we're talking about. This is this nice annular ring shape. A little bit of central clearing. So there's still scale and erythema here, but you can tell the papular rim is much more predominant. And then here you're seeing these nice annular plaques, a little bit of clearing, more predominance at the periphery. This little one with little annular circles all over the chest, neck, and upper abdomen. These less pronounced here, so more central clearing and very thin prominence of that annular periphery, and a very well demarcated, meaning I could take a Sharpie and draw exactly around where it starts and stops. Well demarcated, kind of scaly gray violaceous plaque on the shoulder of this patient with skin of color. Here's a lot of hyperpigmentation, meaning brown discoloration after there was an inflammatory process occurring on the skin. Very common in tinea and just a common phenomenon in patients with skin of color. I tell patients it's the footprint of where their skin was so inflamed previously. So you're seeing the footprint of hyperpigmentation here in that annular distribution. Here's where you're getting more of those papules and pustules within this annular plaque. So this may need some oral antifungal. Here's a well demarcated kind of brawny, rust-colored red plaque on the buttock. And then on the lower abdomen here, very classic for tinea, central clearing, peripheral edge of scale. So treatment for this, a topical antifungal cream is usually highly effective unless you have those papules or pustules, and then it will need oral antifungal pills. We encourage light and loose-fitting clothing. It does take weeks to see resolution of symptoms, but these patients really don't have any restrictions. If it's obvious and noted, then it's recommended that they seek care with their provider to start a topical regimen, but they shouldn't be pulled out of school or kept out of school due to the tinea. We do want to try and keep it covered until it's been treated, but once you're on an antifungal cream or oral therapy, no restrictions. Ringworm of the scalp. This is something we frequently see in our pediatric patients. This is the fungal infection of scalp hair due to the same dermatophytes that cause ringworm on the body. There's a non-inflammatory form, meaning it's not going to be red or pustular, and it resolves without scarring. And there is an inflammatory form, actually, that can have some pustules and can lead to scarring. It's most common in early school age kids and sometimes teenagers. And you get little patches of scale on the scalp, often with some broken hairs and hair loss. That's usually first noted when a family member is combing a child's hair or they're styling their hair and they think that there's been some hair loss. And then you can get some red papules and pustules and plaques that increase in size over time, and it tends to be quite itchy. There's three primary variants. You have a black dot tinea capitis, which is the classic presentation. We'll look at some photos, but you get an area with hair loss and you just see black dots within it. And the black dots are just the hairs inside the hair follicles. They just all got broken off at the skin surface. And so it's just the hair remaining inside the hair follicle. Carrion is the term we use when an area of tinea capitis gets very, very inflamed, red, kind of oozing or suppurative, and it may progress to a scarring alopecia. When you have a scarring alopecia, it can mean you have permanent hair loss of that site. And then FAVIS, which is very uncommon in industrialized countries, but it's very boggy, moist, deep progressive oozing nodules with abscesses and crusting, and that often can cause scarring. So here we have this non-inflammatory, like this pictorial. We're looking at patchy, non-scarring alopecia with a few short broken hairs and maybe a fine, scaly, like little plaque in the black dot tinea capitis. And inflammatory can have a lot more systemic symptoms, actually. You get round areas, non-scarring alopecia, but pustules, crust, redness, itching, and sometimes they get inflamed lymph nodes on the back of the neck, which is one of the most specific findings in tinea capitis. Treatment for this is going to be oral antifungal therapy. No creams or shampoos can treat tinea capitis, and that's because the fungus has gone down the hair shaft, and the creams and shampoos don't get deep enough to actually cause good effective change. Household members should be screened to make sure they don't have any inflammatory condition of the scalp. And when we find a child with tinea capitis, we want to try and isolate them as much as possible until treatment has started. But really, this means just, making sure they're not sharing personal hair care items, hats, combs, brushes, bows, depending on the time of year, whether ball caps or beanies, making sure those aren't being shared. And then all those hair products and hair care equipment need to be cleaned and disinfected or replaced. So hairbrushes that can be disinfected, great. Ones that cannot be need to be disposed of. And then all other hair care, bows, headbands, anything else they're wearing on their head needs to be cleaned or disinfected, and hats as well need to be laundered on high heat and dried with, laundered with hot water and dried on high heat to kill any remaining fungus. It's nothing we need to be incredibly concerned about that it's going to jump from one child's head to another, but we just want to make sure they're not actively sharing combs or head equipment when they're at school. Okay, now the pictures, this is the fun part. So here, so this can look like a lot of different things, especially when we get to the inflammatory conditions of the skin, which we'll talk about later. So the hallmark things here are that this is going to be itchy. It's usually localized to one or several areas and not the whole scalp. But when it gets really bad, it can be the whole scalp. That's usually localized. You're seeing this discrete circular area of significant white gray scale. Here, you're seeing an area of decreased hair with alopecia, some background erythema, and a lot of broken hairs, and maybe some pustules or papules here. This is the black dot tinea capitis. So here it almost looks like they just shaved certain aspects of this young man's scalp, but this is all the hair follicles remaining in the broken off areas where the fungus has invaded the hair shaft. And here, this nice ring shape with some accentuation of the border and some pustules. Again, a good example, a close-up of black dot tinea capitis. Everything is broken off at the hair shaft here. This is a harder one to diagnose. This is just kind of looks like diffuse fine white scale and can be confused for dandruff or what we call seborrheic dermatitis, kind of inflamed dandruff. This would probably be diagnosed most readily by scraping in the provider's office, or if the patient had other signs or symptoms like a focal area that was actually involved. It's hard to tell in this photo if it's focal or not, or posterior cervical lymphadenopathy, and then a very large area here of black dot tinea capitis. This is going to be closer to this like boggy indurated plaque called carrion. So when they get very inflamed, they get pustular and exudative. Here, more inflammation, some pustules and scale, and a nice example of the annular plaque. And this is bordering a little bit on the FAVIS type, so very inflammatory. There's been lots of ooze and exudative scale and crust. Things are very adherent to the scalp. Okay, moving on to pediculosis capitis or head lice. Head lice are exclusively on the scalp. This is different than body lice or any other type of lice. Head lice are exclusively on the scalp. They transmit via direct head-to-head contact. They can survive for up to 4 days on fomites, so on objects, brushes, barrettes, soft plushy toys, stuffed animals. It affects all ages, all races, all socioeconomic statuses, and this is an example here of teensy tiny little nits. There's nits adherent to all the hair shafts here. We're going to talk through what to look for on a lice exam. So there's not really a primary scalp rash. Children can get a rash because they've been scratching so much that it creates some open wounds, or they get like a little itchy eczema type response because of the inflammation from the head lice in general, but it's not a primary scalp rash. And we diagnose it by seeing an adult lice or nits on the scalp. This is a lovely, cute little adult lice. They are about like 1/2 centimeter long. They move very quickly, and they tend to be within about 1/2 inch of the scalp when they're cruising through the hair. And then nits are the ovoid lice eggs. They're about the size of a sesame seed. They're very tiny. And they're gray or white specks that are firmly attached to individual hair shafts. Look through some of those. Here you can see this is the louse, and that's actually a little nit that we're getting cut off at the corner, but that's adherent to the hair shaft. So here we go. This is this one's a little difficult to appreciate, but this hair is just coated in little teensy tiny kind of white gray nits. This child's hair, you see all these little white yellow dots or nits. Close-up of little nits adherent to the hair shaft. And again, here, these look a little more like oval and puffy, all adherent to the hair shaft. So how do we get rid of nits? So you can mechanically remove them with a nit comb. As long as every single nit is removed, it is effective, but it's very time intensive. And it has to be done once per week for at least 3 weeks. So that's the only treatment being done. So pediculicides, topical treatments that kill lice, are less time intensive but do need multiple treatments. Ideally, they're applied on day 1 of diagnosis, and they're repeated at days 8 to 10, which helps and kill the nits, but also any that survive the first treatment, okay? Pediculicides do not remove killed nits from the hair shaft. Okay, it kills the nits, but doesn't remove them. They fall off over several weeks with natural hair shedding. And there are some increasing resistance patterns in our country and worldwide to topical treatments. So classically, things like NICN, which is a brand name over-the-counter head lice shampoo, there's been increasing rates of resistance to its active ingredient, which is permethrin, and sometimes it will no longer be effective. So over-the-counter, you can get permethrin and ivermectin lotion. There is less resistance to ivermectin lotion at this point in our country. And then a prescription can be sent in for patients that don't respond to over-the-counter treatment with appropriate treatment, meaning 2 treatments about 8 to 10 days apart. And the names of those prescription treatments are listed here. And then rarely we will give an oral therapy to treat really recalcitrant head lice, but that's rarely ever needed. What else do? We have them wash their bedding, clothing, towels, stuffed animals, soft toys, anything that can be washed should be washed in hot water and dried with high heat. Vacuumingly aggressively, furniture, carpets, rugs, car seats, high chairs, for it to pick up any nits that may be attached to fibers on those fabrics. And then items that cannot be washed should be placed in a sealed plastic bag for at least 2 weeks. And then then any nit that was there would have hatched and then no longer be viable by the time the object's taken out. And then family members who share personal care products or sleeping arrangements also need to be evaluated and likely treated prophylactically for head lice. Restrictions. Okay, so really importantly, the CDC guidelines state that students diagnosed with live head lice do not need to be sent home early from school. They can go home at the end of the day, be treated, and return to class after appropriate treatment has begun. So really, really importantly, these are very frustrating, but the burden on parents, teachers, families, schools, society for keeping kids out of class due to head lice is not necessary, is what we have determined overall as a healthcare profession and society over the past decades. So really, when it's diagnosed, family needs to be informed, child needs to be treated, and then they come back to school. Nits may persist after treatment, but successful treatment should kill the crawling lice. So after one treatment, nothing is left crawling, but there may be nits there. And head lice can be a nuisance, but they don't spread active disease. Things like body lice do, which we're not getting to in the scope of this talk. And then personal hygiene or cleanliness in the home or school has nothing to do with getting head lice. They're just very common. They can affect anyone. And the no nit policy. So the American Academy of Pediatrics and the National Association of School Nurses advocate that no nit policy should be discontinued, meaning that a no nit policy requires a child to be completely free of nits before they can return to school. But these should not be valid and they should be discontinued for these following reasons. Because many nits are more than a 1/4 inch from the scalp. They're not usually viable. They're unlikely to hatch and be crawling lice, and they may just be an empty casing. So we'd be keeping a child out of school for no reason. They're cemented to the hair shafts. They're very unlikely to be transferred easily to surfaces or other children. And then, as I mentioned, this burden of unnecessary absenteeism is just not necessary given the low risks associated with head lice. And a misdiagnosis of nits is very common during nit checks done by people that aren't actually healthcare professionals, because as you'll see in our later talks, dandruff, eczema, and psoriasis also can cause really fine little white flakes that adhere to the hair shaft that on a quick exam may be concerning for lice, but with underlying background medical knowledge, it's understood that it's not lice, it's a different type of skin disease. Okay, we're going to move on to our cutaneous manifestations of systemic infections. These are systemic illnesses that have a primary cutaneous eruption. They have a rash. Think of chickenpox, shingles, measles, mumps, hand, foot, and mouth disease, which is Coxsackie virus infection. We're going to start with chickenpox or varicella. This is an acute, abrupt onset, highly contagious exanthem, meaning viral rash, presenting on the skin. It's due to a primary infection with varicella zoster virus or VZV. It's spread via respiratory droplets or skin vesicles to the respiratory tract of susceptible children and incubates for 2 to 3 weeks. The whole process lasts less than a week, and in most patients, it resolves without complication. Examples here, you're seeing erythematous macules and little vesicles. It's termed a dewdrop on a rose petal. So think of a little clear vesicle on a little pink macule. Then they can become a little more scale crusty. Once the vesicle ruptures, they form like a little bit of a scab or eschar. And you see multiple crops of new lesions all appearing in the various stages of healing over that 1 week timeline. On the right here, you're seeing a more extensive eruption of varicella, but you see lots of these little vesiculopustules on an erythematous base. Presentation and skin of color, so little erythematous vesicles on violaceous vesicles on an erythematous base, and kind of little vesicles on an erythematous base distributed to kind of the bilateral thighs and lower leg here. clustered around the face. So the skin lesions of varicella or chickenpox can happen anywhere on the body, but you see little pustules here on an erythematous face, kind of open to form some crusting. These kids are at high risk of developing impetigo on top of their chickenpox because of the open wounds that can be present. That's something to look out for. And then you're seeing these little, this is more classic dewdrop on a rose petal presentation here with the little papule on the background, pink or red halo. So these patients usually have fever, malaise, and then rapid progression of a vesiculopustular eruption with the crops of macules, which develop a little papule and then progresses to a vesicle pustule and then crusts up over 12 to 48 hours. And those little crops of lesions keep coming up over a few days before everything crusts in about a week. Varicella vaccination is now routine, so we now see this less commonly. And those who are vaccinated, you can still have kind of a breakthrough varicella actually, but it's usually a milder variant of the same illness. It's contagious from 2 days before the rash appears, so you wouldn't necessarily know until all vesicles are crusted. Doesn't mean all skin is healed, but all vesicles are crusted and there's nothing vesicular, pustular, or purulent. It's usually about 3 to 7 days after the rash starts. And the treatment is really supportive care to treat the underlying symptoms of fever, malaise, and the itch. And rarely are antiviral medicines needed for severe varicella or for those with comorbidities that put them at risk for severe varicella, like certain underlying immunodeficiency disorders or people who are taking other specific medications. Okay, shingles, which is caused by herpes zoster virus. This is reactivation of a latent infection with varicella zoster virus. So someone that has had chickenpox in the past, it becomes dormant within their nerve cells and then can reactivate upon certain triggers. It is less contagious than varicella. It is uncommon in children overall. Primary risk factors for a child getting shingles or zoster are if mom had a chickenpox infection during pregnancy, if the child had a varicella chickenpox infection in the first year of life, or the child is immune compromised. Children often do not have the classic prodrome of burning, tingling pain in the affected area before a rash starts. In adults, classically, people talk about with shingles, you get this like burning, prickling sensation in an area of skin before the rash starts, and that's much less common in pediatric patients, so it can make it harder to diagnose. They're little grouped or confluent vesicles on a very erythematous base in a single or several contiguous dermatomes. So these are nerve pathways that are associated with certain portions of the skin, and they run in bands according to certain regions of the body. These lesions crust and resolve in about 1 to 2 weeks. They can be painful and itchy, and treatment is usually supportive care, but sometimes we do consider antiviral therapy with oral antiviral medications. Here you can see this like beautiful, well-demarcated dermatomal vesicular pustular eruption on erythematous base. And here this is traveling down the thigh. You're seeing lots of intact vesicles, but kind of these grouped and clustered, well-demarcated vesicles, very classic for herpes zoster. More examples here up close. You're seeing these little vesicles on an erythematous base, and this top left photo is kind of clustered on the left upper back. Here you can see it running in a band-like distribution on the arm. Very classic dermatomal distribution on the back in that band-like area with some kind of gray-black crusted scabs. This is probably in early phases of resolution. And then a very severe variant that can happen on the upper forehead or eye. And if you're getting vesicles in a dermatomal distribution in this location, it's really, really important that patients are expediently evaluated by ophthalmology, because if you get shingles or varicella or herpes virus infection within the eye, it can actually cause permanent damage, keratitis, and visual loss. So VZV versus HCV transmission, so chickenpox versus shingles transmission. An individual with chickenpox, varicella zoster virus, primary chickenpox, can transmit chickenpox to someone that is susceptible, who hasn't had or hasn't been vaccinated. An individual with shingles, herpes zoster virus, can transmit chickenpox to someone that is susceptible. Someone with shingles cannot give shingles to another person. Shingles is coming out in your own body, but the virus that causes shingles is what causes chickenpox. So if someone with shingles comes into contact with someone who has never had chickenpox or not immunized, they can give that person chickenpox. You cannot transmit shingles to another person. Okay, moving on to measles or rubeola, something we do not frequently see in the United States anymore. It's a highly contagious virus. Most children in industrialized countries have been vaccinated. It's transmitted via the respiratory droplet route, and it can remain viable for up to 2 hours in airspace after an infected person leaves an area. Hence the reason it is so highly contagious and very common in close, crowded conditions such as college dormitories, military campuses, homeless shelters, areas where people are in a very, very small space for prolonged periods of time. The virus enters the upper respiratory tract. It incubates for 1 to 3 weeks, and then the rash develops about 14 days after exposure. Patients are considered contagious from 4 days before the rash through 4 days after its appearance, not resolution, but after it appears. And the classic measles rash is called a morbilliform eruption. There are many, many rashes that are morbilliform, which means measles-like rash. So there's a lot of rashes we see, including viral rashes and drug rashes that look like measles, but they're not. And it's easier to say that because the prevalence of measles is low in our industrialized country. But you'll see thin erythematous papules and pink macules, as you can appreciate on this young girl, very diffusely distributed. And we'll go through some more photos, of course. The cheeks and chest and abdomen of this young boy, kind of erythematous to pink, thin papules and macules diffusely distributed. Classically, patients get a prodrome of fever, coryza, which is nasal congestion, cough, and conjunctivitis for about 3 to 4 days, and then they get the rash. Now, measles has been declared eliminated in the United States as of 2000, but outbreaks still occur, and most are associated with the import of measles by unvaccinated international travelers, and that then causes outbreaks in communities where there's clusters of unvaccinated children. You get oral lesions, which is called an enanthem. So the cutaneous surface, non-mucosal is an exanthem, but oral lesions associated with an infection enanthem. Oral lesions called Koplik spots, which are little white or sometimes red papules on the buccal mucosa or the hard palate. These are one of the first and most specific signs. They pop up first and they resolve as the rash appears. And then you have, as I mentioned, little pink macules and papules starting at the forehead and behind the ears, and then spreading caudally down the neck, upper extremity, trunk, and legs. The rash peaks for a few days and then fades. And remember, in skin of color, the erythema or pinkness I'm describing may be more violaceous or dusky or brown. So examples of Koplik spots, these teensy tiny white kind of papules and vesicles on the buccal mucosa, more of an erythematous petechial variance. And this one's really difficult to appreciate because of the lighting, but there's a few little white Koplik spots on that buccal mucosa. And then erythematous thin papules, slightly violaceous hue on the face here. You can see kind of starting on the face, ears, and behind the ears on the upper neck, and then spreading cephalocaudad to involve the neck, the chest. You can appreciate that kind of diffuse distribution. Mumps, less of a true skin rash per se, but it's often talked about in the category of like measles, mumps, rubella, varicella, because that's a vaccination protocol, which we'll briefly talk about. But mumps as a virus also spread via direct contact with respiratory secretions and saliva. It can be transmitted via fomites. It incubates for a couple of weeks, and then patients get a fever, headache, malaise, and myalgia, so neck muscle pains, especially of the neck. And then the big hallmark of mumps is parotitis, so parotid gland inflammation. So our parotid salivary glands live here within our lateral cheeks very deeply. They get very inflamed over 48 to 72 hours and then resolve over about a week. Rates in the US of mumps have rapidly declined since the 1960s when vaccination was introduced. You're looking at the posterior neck of a young boy here, and what I want you to appreciate is the fullness of this aspect compared to this side, and this is like left parotid inflammation in the setting of mumps. Overall, mumps is a benign illness. It's self-resolving. Here you can appreciate the fullness of the neck of this young man, and then this is a little harder to see, but this young girl, this is kind of the sideburn region that you're seeing. And then she has a significant fullness extending from the left preauricular cheek down to the neck, and that's all parotid inflammation. And it's this inflammation that's very painful and tender between the earlobe and the angle of the jaw. So it all occurs right here. Rubella or German measles, again, something we see infrequently because of vaccination protocols in our standards in our country. Transmission of rubella is via respiratory route, again, incubation for about 2 to 3 weeks. Prodrome of viral symptoms, irritability, mild conjunctivitis, headache, fever, some mild URI symptoms up to 1 day to a week before the rash. The rash starts on the face and spreads caudally, generalizes over 24 hours, and disappears within a few days. So it's a shorter presentation of the rash than measles. And it often spares the palms and soles, not always, but usually. And here you can appreciate these kind of like thin pink non-scaly papules that are on the face, the trunk, the arms, very diffuse and widespread. Very similar appearance to measles. I can't say just by looking at a photo that I would know the difference between rubella and measles without history, context of symptoms, how severe it was, and the duration of disease. So pink to erythematous macules and thin papules on the arm here, very diffusely distributed over the trunk, arms, and legs in this young child. On the face and upper arm of this child, and you're seeing on the upper posterior arm and back these thin pink papules. So briefly, just because we went through a whole chunk of vaccine preventable diseases, the trivalent measles, mumps, rubella, or MMR vaccine and the varicella vaccine exist to prevent that category of diseases we just went through. The MMR vaccine is a live attenuated combined vaccine, and varicella is a live attenuated vaccine. It's administered in two doses, with children most often receiving the first dose between 12 and 15 months of age, and the second dose between ages of 4 and 6. The estimates of effectiveness of the MMR vaccine are about 99% in measles prevention after the second dose, and over 95% in prevention of mumps, and 90% in prevention of rubella even after a single dose. Varicella vaccine is 70 to 90% effective in preventing varicella, but more than 95% effective at preventing severe varicella. So what we know is that the vast majority of measles, mumps, rubella, and varicella are now vaccine preventable diseases. And although they're usually mild, self-limited, benign illnesses, they can have some serious comorbid complications. So standard vaccination is what's going to be the most important thing we can do to advocate for our patients to keep them healthy. Herpes simplex virus, or HSV. This is cold sores, fever blisters caused by HSV 1 and 2. Cold sores are common worldwide. They usually affect the oral, labial, and genital regions, but any skin area can be affected by HSV. They're highly contagious, spread by direct contact with either a virus-containing lesion, saliva, or other body fluids during the viral shedding process. The virus, and this is similar to kind of the shingles phenomenon, the HSV virus establishes lifelong dormancy or latency in the dorsal root ganglia of the nerve, so it's always there, and then it can reactivate randomly, spontaneously, sometimes with trauma to the area of skin, UV exposure, so sunlight, fever, or immune suppression. HSV, what I'm going to focus on here, because there's lots of different types and categories of herpes simplex virus infection, are that primary infections are most common in childhood, and a primary herpes simplex virus infection is different than like recurrent cold sores. Primary is usually going to be oral labial gingivostomatitis. So here you see this like very confluent eruption of vesiculopustules. You see these well demarcated vesicles on the upper and lower cutaneous lips, very sharply defined borders with vesicles and pustules, pretty extensive around that mucosal surface, and that's characteristic for a primary HSV infection. It's more severe than the recurrent symptoms, and it can be localized or widespread to the entire oropharynx or lips, and these patients can have systemic symptoms with fever and malaise. The primary episode resolves over about 14 days, but viral shedding can remain for weeks on end. So it's really hard to know when someone's contagious or not. So HSV, as I mentioned, a recurrent disease usually lacks constitutional symptoms, meaning that primary infection is the worst one. But when you get recurrent outbreaks of your cold sores, for the colloquial term, they usually are locally maybe a little tingly or burny, but you don't otherwise get systemic symptoms. You can get itching, burning, or pain that precedes the development of the little vesicles or pustules. And then they're often grouped together on an erythematous base. So here you see a bunch of grouped vesicles starting to crust on an erythematous base, and very classic grouped pustular vesicles on an erythematous base on the nasal bridge here. More examples of grouped vesicles on an erythematous base. Grouped vesicles here, kind of crusted here, but following this kind of linear pattern. And then grouped vesicles on an erythematous base on a fingertip, we call that herpetic Whitlow, and it's just one of the variants you can see of cutaneous HSV infection. They are contagious until they're completely crusted over. Treatment is really only helpful as far as oral antiviral therapy if it started within 24 hours of the onset of symptoms. So oftentimes patients aren't treated because they come to care too late in the course. And ideally, we keep exposed areas covered, use frequent hand washing. These patients don't require any specific restrictions, ideally just trying to keep it covered. When patients have recurrent, very frequent outbreaks of recurrent oral labial HSV, cold sore virus infection, sometimes they get put on episodic therapy. So they have a prescription for antiviral pills at home that they take at the first sign or symptom that they have a cold sore, or occasionally they'll be put on suppressive therapy, which means they take antiviral medication every single day to try and prevent flare-ups of their recurrent cold sores or oral labial HSV. Enteroviral exanthem, so different sort of viral infections. This includes hand, foot, and mouth, typical hand, foot, and mouth disease. Kids get fever, malaise, and the little gray-white kind of football-shaped vesicles on the palms and soles, and we'll look at some pictures. And then vesicles and erosions on the buccal surface, the palate, the tongue, usually very painful. They don't want to eat very much. They're very uncomfortable. They get lots of cervical and submandibular lymphadenopathy, and it's usually caused by Coxsackie virus A or B, or enterovirus 71. Atypical hand, foot, and mouth is quite common, and it's caused by Coxsackie virus A6. This is a little bit different because even though it's called hand, foot, and mouth, the vesicles really predominate on the extremities, sometimes the palms and the soles and the perioral area, but less so true intraoral involvement. So this is classic hand, foot, and mouth, these kind of gray-white football-shaped vesicles with an erythematous rim. This is on the palms and on the soles of the foot of this young child. And then you see this kind of red, white, purple vesicles on the knees of this young child as well. This child also had classic lesions of the mouth, the palms, and the soles. Atypical hand, foot, and mouth doesn't always look this exuberant, but this is an exuberant form. But what you're appreciating is it's more common on the extensor surfaces. It's more very edematous papules than it is vesicles. So you're seeing edematous papules and pseudopustules and vesicles on the extensor knees and hands, and predominance of the perioral area. So not necessarily in the mouth, but on the facial cheeks around the mouth. Here you can see these edematous papules and pustules. And then some little pediculate macules on the palms. The management of typical or atypical hand, foot, and mouth is going to be supportive care. They can develop aseptic meningitis, even encephalitis or myocarditis, which is very, very, very rare. Most kids do very well. Here I'm showing you a picture of kind of an atypical hand, foot, and mouth with some edematous papules on the extensor elbow. And then a very common finding is onychomedesis, which is painless shedding of a nail plate. Here you can see this is the nail plate just distally detaching and falling off. This is really common about 4 to 6 weeks after a hand, foot, and mouth infection. It's not fungus, it's not dangerous. The nails will grow back totally normally, but a common phenomenon we see after a hand, foot, and mouth infection. In atypical hand, foot, and mouth, I'm just showing you it can be really common to affect the perineal area and buttock area, and with these edematous kind of papules and some vesicles. The perioral region, about at 80%. Intraoral, only about half of patients. It's going to be more frequent with classic hand, foot, and mouth. And then palms and soles frequently involved with kind of intense edematous macules and papules. Extremities almost uniformly involved. Here you can see very robust erythematous scaly plaques on the lower legs here. And the torso can sometimes be relatively spared, even though you can see this is quite extensive on the upper chest and arms for hand, foot, and mouth. So Coxsackie virus infection, eczema coxsackium. What that means, you're getting a Coxsackie virus infection. So this rash we've been looking at and talking about, you get accentuation of that viral exanthem in a prior area of atopic dermatitis or eczema. So it can really, really accentuate in the areas where a child has previously had skin flares of eczema. And then we talked about the onychomedesis. So nail matrix arrest, essentially the nail matrix, which is where the nail grows from, gets a little shock to it, stops growing, and painlessly sheds 4 to 6 weeks later. The eczema coxsackium phenomenon. So what you see is this looks like classic areas for childhood eczema. So the popliteal fossa, back of the knees, and the antecubital fossa, so the creases of the upper arm. And you just get really intense redness, scaling, flaring of those areas. But it's nothing that we need to specifically treat. unless it becomes infected with bacteria otherwise. So it looks more intensely red. It can be itchy, a little bit uncomfortable, but we can treat with emollients, so moisturizers, topical steroids, antihistamines if it's itchy, and supportive care. On the right here, you can see kind of these circular erosions and honey-colored crusting. So this child's eczema coxsackium got infected by bacteria causing impetigo. And this is the concern for complications. So something you want to monitor closely to make sure that they're not developing further skin infection. Examples of eczema coxsackium here, this child had some pretty significant pre-existing eczema and then developed a flare of it within all the preceding areas when he got Coxsackie virus infection. Okay, pityriasis rosea or PR. This is a very common self-limiting rash. It starts with what we call a herald patch, meaning like a larger, scaly, like pink, red, orange patch. This is classically going to be a herald patch, kind of pinky orange with that Colorado scale, pink orange patch or thin plaque superficial scale. It often follows Langer lines of cleavage, which are skin cleavage lines. If you look at the back of an adolescent or an adult, this rash kind of comes down on a Christmas tree distribution, and that's Langer's skin cleavage lines. About 2 weeks after the herald patch starts, you get a bunch of little small scaly pink to orange macules and thin papules in those skin cleavage lines of the Christmas tree rash. Patients can have some systemic symptoms, malaise, fatigue, nausea, headache, joint pain, sore throat. It's the etiology of PR is linked likely to a viral infection with human herpes virus 6 or 7. So very, very common infection that most of us are exposed to by the time we're teenagers. And then in a patient with skin of color, you can get actually a little more bumpy or papular eruption of the skin. This is classic pityriasis rosea, maybe a herald patch here, kind of pink and scaly, and then a bunch of little small, similar, if you think about a mother lesion, and then a bunch of little daughter lesions that look similar, and then pink scaly plaques on the back here. In a patient with skin of color, it can look a little more violaceous, larger herald patch here, and a bunch of small, scaly papules on the back here. And then it can have that a little bit of annular architecture. That's very, very common in certain types of pityriasis rosea. And I just want to point out, we've been talking about eczema, not eczema. We talked about eczema coxsackium. So when Coxsackie virus infects someone that's had baseline eczema, it can flare it. In a patient that has eczema and they have a significant skin flare, sometimes people worry it's just impetiginized, but really it can be infected with viral particles as well. So this child's facial eczema, they have red scaly plaques, looks like they've got some honey-colored crusting too. So could it be impetigo? Yes. But what really concerns me is these like very discrete vesicles on an erythematous face. And this child actually has eczema herpeticum. So their eczema got infected by herpes simplex virus infection. This can be severe and dangerous because it can spread really rapidly. Their eczema creates kind of open wounds all over their body. So the HSV can kind of jump around and really run wild all over their skin and give significant systemic symptoms if it's not caught early and treated. It's usually from HSV1. Here you can see all these punched out erosions on the cheek of a child and then the honey-colored crusting on top. So this is HSV1 infection that's probably also got bacterial superinfection. Okay, we're going to talk about cutaneous hypersensitivity reactions. So this means the skin is manifesting something that's underlying going on in the body, but this rash itself is not contagious. We have secondary skin manifestations due to an underlying disease process, which is often an infection, but these are going to be a category of urticaria or hives, urticaria multiforme, and erythema multiforme, which we'll go through. Urticaria or hives, these are wheals, which is the wheals are the red, smooth, kind of swollen skin patches. And then angioedema, think about a hive of deeper skin surfaces, so swelling of the subcutaneous tissue, but there's usually no color change associated with it, or you can have both. You have acute hives, which is what we term if you're getting hives for less than 6 weeks, coming and going, or if you're getting hives consistently for more than 6 weeks, we put that in a category called chronic hives. The most common cause in kids is a viral upper respiratory tract infection. So it's usually not a food allergy. It's usually not a medication exposure. It's usually they're just getting a cold if they've been exposed to something. It can be due to foods and medications. It's just not the most common cause in kids. A single lesion of hives or urticaria will last less than 24 hours. but the overall episode of getting hives will be much longer. So if they come in with a hive and I draw around it with a Sharpie, that specific hive will be gone within 24 hours, but they may have developed 20 more on their body, and that's normal and classic for hives. You can see this kind of smooth erythematous, edematous plaques on the arms, some with kind of funny architecture, some well-defined borders, some poorly defined on the face and neck of this young child, diffusely on the lower legs and back of this toddler, and then kind of fading medially with sharp demarcation of the periphery on the legs of that child. If there is concern, of course, for any airway involvement, and not just the child is worried because they have hives, so they're breathing heavily, but they are getting facial swelling, facial edema, neck swelling, respiratory distress, then emergent intervention is needed with IM or subcutaneous epinephrine and emergency department transfer, of course. But without those concerning warning signs, you can give antihistamines such as Zyrtec, Benadryl, and observe to ensure that they're not developing any signs of anaphylaxis. We use sedating antihistamines like diphenhydramine or Benadryl, and non-sedating, which is tyrosine, levocetirizine, fexofenadine, desloratadine, or loratadine, and that can often significantly control or improve their symptoms. This is an example of like a little case presentation. So imagine this little toddler, and this could be any school-age child. They have some congestion and a runny nose for a few days, a single low-grade fever, and this rash, which looks pretty striking. You're seeing like background erythema, these like round circular violaceous areas. It's very widespread and diffuse, but this little one is overall feeling pretty well. They don't have any respiratory symptoms at all, as far as no concern for airway involvement or anaphylaxis. So what is this interesting pattern? This is Urticaria multiforme. It's a subset of urticarial reaction. So it's just a type of hives. It is benign and self-limited in a pattern seen more common in kids, usually after illness. And you get these arcuate, annular, polycyclic patches and plaques, often with kind of a dusky or purple center. Sometimes people term it purple urticaria because you get that like nice polycyclic or annular rim and the central purple coloration. Again, an individual lesion should last less than 24 hours. They can get angioedema, so swelling of the soft tissues, especially of the hands or the feet, more common in kids. Dermatographism, that's skin writing, meaning if you took the back of a cotton tip applicator or a tongue depressor and gently scratched the skin surface, within a couple minutes, they would develop a hive in that area. That means they have a higher level of histamine in their body at that time, which makes sense because they're having hives, which is an allergic process. They respond well to antihistamines and they go away spontaneously. I bring this up because it can look so striking, but it's just a very common type of hives in children, seeing these annular and polycyclic, extensive patches, kind of a dusky center. This child otherwise feels well. You can probably appreciate a little bit of dorsal hand edema also. This is the inner thigh of a young baby with perfectly annular urticarial patches. On the face of a young one, kind of annular and polycyclic here, and then you can appreciate that polycyclic nature on the upper chest, annular and polycyclic on the back and on the chest of another child. All urticaria multiforme. It's hives, it's just a type of hives. Again, here kind of lacy, reticulate almost, and then they often do resolve with kind of like a bruising or ecchymotic appearance in children, and that's just part of the fading process. And then here you can appreciate some cheek edema in this young babe, and then dorsal hand edema. That's going to be more common in kind of like toddler age, but you still can see it in younger kids. And then erythema multiforme. Erythema multiforme is in the category of hypersensitivity reaction, but it is not hives. It's a skin self-limited hypersensitivity reaction occurring on the skin and mucous membranes, meaning oral mucosa, nasal, ocular, and GU. It has a classic target lesion, so kind of a dusky center. I'll point out to you here, kind of a, probably this one here, dusky center, rim of peripheral edema and pallor, and then darker rim at the edges. It favors the palms and soles, but can be anywhere. A single lesion will last days to weeks. So unlike the hive variants where a single lesion lasts less than 24 hours, it lasts days to weeks. And you can see significant involvement of the oral mucosa and then sometimes conjunctiva or urogenital mucosa. These patients could have a low-grade fever. It's often triggered by HSV, especially in older kids and teenagers, or some other viral illness. And really what we do is provide supportive care, making sure that their oral erosions are not painful enough that they can't eat or drink and stay hydrated, pain control, and then the rash spontaneously resolves without scarring. Another example, a beautiful target here on the face of this young child, involvement on the palms here and dorsal feet here. So this is something that we see very frequently in the office. It can be very, very frustrating and hard to diagnose, but it's completely benign and not dangerous. So imagine a 6-year-old comes in and they have recurrent pink bumps on the arms and the lower legs. They're itchy. They go away and they come back. No one else in the family has any similar eruptions. They don't have any pets at home, but they just can't figure out what's going on. So these are kind of pink tan edematous papules on the dorsal hand here. He's got some on his arm and on his leg. What are our thoughts about what this could be? I mean, truly, it could be anything. Is it hives? I mean, it doesn't sound like it based on the time course, but it could be. Molluscum bumps? Maybe if I saw it in person. Is it a viral rash? This is papular urticaria. This is a hypersensitivity to bug bite reaction, super common in school-age kids, elementary school-age kids, that just improves over time. School-age kids' immune systems can react like crazy to bug bites sometimes. They can get really erythematous, almost cause like a vesicular, pustular, cellulitic-looking appearance, but it's really all just a bug bite reaction. So papular urticaria is this recurrent eruption or hypersensitivity to bug bites. And we don't know what bug. I cannot tell you by looking at your skin what bug it is. Most families really want to know what's biting their child. I don't know. It could be a mosquito, a flea, a bed bug, a carpet mite, anything that can come in contact with them. You get little edematous urticarial papules. They're not urticaria, but they're like pink, swollen papules. Pretty small. They're often kind of grouped or clustered, and they last for a few days to a few weeks. They can be eroded or crusted because they've been scratching because they're itchy. A flea bite is the most common cause. And then what happens is a group of them resolves with maybe like a little pink mark or some hyperpigmentation. And then they often get recurrent episodes in the same location. And it's kind of like the bumps get better, and then when something bites them again, everything kind of reactivates and they get little papules all over again and kind of go through the same course of healing. Really hard diagnosis to get families to buy into because they feel like you're telling them that their house is dirty or they're not caring well for their child because they're getting bit by something. And it has nothing to do with that. It's just a child's kind of overactive immune system reacting to standard bug bites that any of us could get. Treatment, we give oral antihistamines like Zyrtec, some topical steroids as needed for when they have bumps, and then anti-itch over-the-counter lotions containing an ingredient called pramoxine. It's an anti-itch property that does not contain a topical steroid that can be really safe, so really effective and very safe to use. And then insect repellents when they go out, protective clothing, so long sleeve, long pants, spraying insect repellent around the wrists and the ankles, and just being cognizant of when they're out in like really grassy or wooded areas. Okay, moving on to our last category. So inflammatory skin disease. These are things that are not infections, but are often on the differential of things that can be infectious. So atopic dermatitis, psoriasis, alopecia areata, and seborrheic dermatitis. Atopic dermatitis is just classically termed eczema. This affects about 17% of kids. It's very common. It's a chronic disease with intermittent exacerbations and remissions. There's a very multifaceted approach to treating it in our office. We have to treat the itch, we have to prevent skin infection, and control the inflammation on their skin, which is their red scaly plaques. And the effective treatment really requires a lot of diligent time on part of provider, parents, and patients, and good understanding of the expected outcomes to get good improvement. So it's very itchy. It's often in school-age children on the flexural surfaces of the arms and the legs, so the antecubital and popliteal fossa. And because of the chronic open wounds, as we've already talked about, you can develop bacterial infection on top of it, which is impetigo, or viral superinfections such as eczema herpeticum with HSV or eczema coxsackium with coxsackie-virus. There's really no specific precautions for a child's skin. They may be sensitive to temperature or weather changes. And a lot of times when weather temperatures are rapidly changing, children's skin can flare during that time. And when we're in very cold, dry weather in the winter, that can be hard on a lot of children with sensitive skin. But some children flare up more in the hot, sweaty, warmer weather months too. The itch can be highly distracting, especially at school, and it's associated with the complex of the, atopic complex of asthma, environmental or food allergies, and kind of like seasonal allergies, hay fever as well. Treatments, we treat with lots and lots of liberal, bland emollients, meaning moisturizers, things like Vaseline, Aquaphor, thick moisturizing creams. We use topical steroids and steroid-sparing prescriptions, oral anti-itch therapies, antihistamines, light therapy or phototherapy, which is a treatment we offer here in our office. That's one wavelength of UV light that reduces inflammation in the skin. And then there are oral and injectable medications, many and highly varied treatments, but just to give a little background context. As we mentioned, atopic derm can become secondarily bacterially infected with bacterial and viral infections. And this is one of the things where it gets most confusing of like, oh, is that eczema or do they have impetigo or infection on something on top of it that needs to be treated? They can get a lot of scalp involvement too with background redness and fine white scale that can sometimes be concerning for something like tinea capitis. And here in a patient with skin of color, you're seeing kind of a thick, scaly plaque of eczema. And here on the anterior knees, this is called lichenification. This is long-term, long-standing eczema that causes kind of thickening, darkening, and increased texture of the skin. More plaques of atopic dermatitis or eczema. So erythematous kind of eroded, very widespread on the lower extremities of this child. More hyperpigmented and violaceous in this patient of skin of color. Behind the knees, you can see kind of some of these open cracks and serous exudate, which is probably evidence of bacterial superinfection. And then on the scalp here, you're seeing a lot of background redness, probably some erosions from scratching, and then superficial coarse white scale. And that scalp is very inflamed and probably very itchy. Psoriasis is a different type of chronic inflammatory skin disease. It causes usually more discrete, kind of circular oval plaques. Atopic dermatitis usually is a little less well-defined, kind of like a smattering of scaly red areas, but not so well-defined. You could kind of draw around it with a marker. Psoriasis tends to be pretty well-defined, thicker, scaly, pink-orange with white, yellow, silvery scale on top, and it can be anywhere on the body. But places it loves are going to be the scalp, knees, elbows, belly button, and face. And then there's variants that like the intertriginous site, so the armpits and the groin. And importantly, it can be associated with underlying systemic inflammatory disease, such as psoriatic arthritis. So very classic psoriasis here, sharply demarcated erythematous plaque with white silver scale overlying here on the knee, extensively on the back of this adolescent. And then a patient with skin of color, it looks more violaceous or hyperpigmented, but well demarcated with the scale. And then the scalp involvement is what can be really, really tricky. It's hard to get good effective medications on the scalp, but tons of redness with thick, white, yellow, coarse scale that families are often really concerned is an infection, but this is all underlying inflammation. And here you're saying thick, white, coarse adherent scale, and then a cluster of yellow adherent scale here, but you can see the background underlying scale there. Treatments are numerous and out of the scope of this discussion, but topical creams and ointments, the phototherapy that I mentioned is helpful for psoriasis, also many oral and injectable medications, and it's a chronic disease with expected exacerbations and remissions. Seborrheic dermatitis, this is kind of the medical term for inflammatory dandruff. Babies can get this, it's kind of a component of cradle cap, and then it can have a resurgence in kind of later elementary age kids and lots of adolescents. It affects skin that are rich in sebaceous or oil glands. So scalp, the nasolabial folds here, eyebrows, ears, chest, and some of the skin folds. As I mentioned, it peaks in infancy and again in adolescence and early adulthood. We think what drives part of this is malassezia, which is a commensal organism. So yeast that's always on all of our skin, but in certain times of life, it can cause an inflammatory reaction that gets scaly and red and itchy. There's an overlap on the scalp of seborrheic dermatitis and psoriasis. We call it sebopsoriasis. You can see an overlap of these two things. What you're appreciating here is this very thin, well-demarcated pink plaque with some scale on the anterior forehead of this young girl. And then the background of redness and fine white scale here. This erythema on the background of fine white scale over the forehead and eyebrows. Probably tracks down to the nasolabial folds too. And this patient with skin of color has significant post-inflammatory hypopigmentation. So this is the inverse footprint of where their skin was so inflamed from their seborrheic dermatitis in all these areas. Seems like they've probably been treated now, but they have that footprint of discoloration that will improve over time, but can take weeks or months. It's itchy, it is. Treatments, medicated shampoos, and we use a different combination of topical steroid solutions, creams, lotions, and shampoos. But usually you can start with at least an over-the-counter Head and Shoulders or Salsa Blue, and sometimes that will take care of it. And then alopecia areata. This is a cutaneous autoimmune disease causing non-scarring patches of hair loss on the scalp, but also eyebrows, eyelashes, and sometimes body hair. There's no redness or scale. It is not itchy or painful. There's no pus bumps or anything like that. Usually it's misdiagnosed, or the most common misdiagnosis consideration is going to be a tinea capitis, like the black dot tinea capitis. But notice here, this is smooth. There's no black dots in there, those little tiny hairs. This is smooth and not scaly. Alopecia areata is very unpredictable. It may come and go, it may fully resolve, or may progress to full hair loss. And we have many, many treatments, but there's no one best treatment for each patient or family. And it can be very psychosocially distressing for children, especially adolescents and especially adolescent females, to be losing their hair. Hair has a lot of personal connotation and a lot of stigma in our society. When someone does not have hair or is losing hair, it can be very challenging for adolescents. Here you're seeing very diffuse alopecia areata with lots of circular coalescent patches of non-scarring alopecia, an area of non-scarring alopecia of the eyebrow. An up close view, you can see there's no black dots here, and a very well demarcated patch without any black dots on the post-auricular scalp there. Really no restrictions for these children. Sometimes I do have to write letters allowing them to wear a head covering at school, which should be fully supported because we're really just trying to make sure they're empowered to feel as good about their skin as they can. They didn't choose to have an autoimmune skin condition. Psychosocial support and being aware of bullying. It's something I talk about actively with my patients when they're in the office, because I want to know if someone's commenting to them, are they telling teachers? Are they telling care providers? Are they talking to family about it? Because that's a modifiable behavior and an important time that we can provide education to our other students or family members. Lots of treatment options, like I mentioned, that really depend on the patient, the age, and their distress level over their alopecia, but it's not contagious. And I think just making sure we empower these children to feel as good as they can in their own skin, whether it's wearing a head covering, wearing a wig, doing treatments or not doing treatment. It's not a dangerous condition, so they can choose not to treat. The treatments are often time consuming, painful, and can incur some significant risks depending on if it's like an oral medication that requires blood monitoring or immunosuppression. Overall, just to be aware of it, it's not infectious, and it is something that patients need a lot of support through. Okay, these are my references, and this will conclude our talk. I hope you learned something about how to distinguish between when a rash is really truly worrisome, when it may need some follow-up, and when it's nothing to be worried about and can be reassured and sent on. Please don't hesitate to reach out for questions or concerns. I'll make sure that my contact email is posted along with the presentation. Thanks for your attention and take care.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.